Good morning, everybody, and welcome to another monthly live stream with NCAN. Today, I am Mike Wayman, of course, from NCAN. Today, we are joined by my sister, Trisha Wayman. Normally, it would be either my mother or my father, Bob or Marianne, the founders of NCAN, but they are finally on vacation, finally doing something else, which is awesome because we all know how much how crazy they go and how much they're putting their lives into NCAN. So a nice breather is good. So Trish and I are going to be helping us out. So today we are joined by Dr. Sasson. He is from the University of Stony Brook. How are you? Good. Thank you for joining us this morning.
Thanks, Mike. Thanks, Trish. Good morning, everybody. Good program.
So before we get into everything, I want to remind everybody, please text in your questions at 516-584-4576. I will be running that across the bottom of the screen all morning. This is text in only. Do not call because we won't answer. It is only a text. So before we get into it, Dr. Sasson, how did you get involved in NETs and tell us a little bit about your practice and where you practice?
Sure thing. How about a little bit about myself? So I'm originally from the East Coast in New Jersey. I did some surgical training in San Diego, followed by a fellowship training at Fox Chase in Philadelphia. And probably at Fox Chase in Philadelphia, started getting specialized training in endocrine tumors, particularly pancreatic and carcinoid and small bowel neuroendocrines. Over the course of my years, the names of these tumors have changed. So I'll try to keep things standardized. And then in Nebraska, where I was for 18 years, I really had a focused practice where I saw probably about 20 to 25% of my practice was neuroendocrine tumors. And so I developed a niche practice for that right over when I was recruited to lead the efforts at Stony Brook University. So a long-time interest in neuroendocrine tumors for the entirety of my career.
That's great. Trish, do you want to start with a couple of questions here? We're already getting questions rolling in. Again, just text your questions and we'll start those up in a few minutes.
Sure. We're going to get started a little more on the basic level here, Dr. Sasson. I would like if you could share with us a brief introduction to neuroendocrine tumors, including where they are found and where they are most common.
Sure thing. So that's a great question, and I'd say that obviously, I specialize in GI malignancy. My practice is focused mostly on pancreatic neuroendocrine tumors and small bowel neuroendocrine tumors, because those are the two most common sites we see them in the GI tract. But overall, the next biggest group would be lung. We do, if we were to look at all neuroendocrine tumors, lung and the GI are the two most common sites. And in the GI tract, as mentioned, it's the pancreas, small bowel. Now, of course, I see patients with gastric carcinoids and colon carcinoids and rectal carcinoids, but predominantly the main group of patients who have typically some sort of clinical specialty is going to be the small bowel neuroendocrine tumors and the pancreatic neuroendocrine tumors. Although I do think that if you have gastric neuroendocrine tumor, you really need to see a specialist because it's so uncommon that you really need to see somebody who knows how to manage them, because they are very different than most other types of neuroendocrine tumors. So they could be they do require some additional expertise.
Thank you. What would you say is the most important thing for a patient to share with you when they come in to see you? Is there anything that someone can be recording ahead of time so that way you have any helpful tools that they can give you in treating them and coming up with a plan?
Yes, that's another great question. I do find that, although you do have a lot of patients who, when they're diagnosed with a tumor, do a lot of research, but I would say that my neuroendocrine patients are probably the most well-read of group of patients come in who have done a lot of research, spoken to a lot of different people. And I think that's great. I will say probably one of the challenges that I have when treating patients with neuroendocrine is that many patients will go on and share their stories of their tumors with patients and try to compare their treatments. And although I see that, I do caution patients that unlike colon, for example, which has surgery or chemotherapy, that's it. Those are your two choices.
Right.
Endocrine tumors have so many more choices for treatments, and not that. Whereas other tumors like breast cancer or lung cancer have a typical or more uniform pattern and growth spread, neuroendocrine tumors are so varied. They are so distinct that I can see patients in my practice, and this happens very often when I have my residents and students who join me, and we'll see 3 or 4 patients with metastatic neuroendocrine tumors, and I did different options for each of those patients. And they say, well, how, whereas if you had metastatic colon cancer, you're getting one option for the most part. As for when you have metastatic neuroendocrine tumors, the diversity and the heterogeneity of patients and their tumors and their tumor growth makes it very, very difficult, if not impossible, to compare to patient. It's really challenging to do that. And so I've had patients who've known each other say, why, I see, Mary's getting this, but John is getting that. And you have to go in to explain that their tumors are behaving differently. Unlike other cancers where that's not so much, it really is a big factor for patients who neuroendocrine tumors. So I do think, being aware of the diversity of the different kinds of neuroendocrine tumors and their growth and their behavior is very important for patients to understand. Probably critical and one of the main factors I use in helping guide which of the many treatment options I tend to recommend for my patients.
Oh,
that's great.
okay.
I have some questions that are rolling in. One thing that I will ask everybody, the last time we had this, we had people actually sending charts and stuff. Please try not to get too personal with the questions and too long with the questions. We do want to try and keep this as a pretty decent overview and not necessarily go too deep into one specific case. So we're going to start out here. What makes a NET tumor unoperable or inoperable?
So I guess that there are several components to it. One is obviously location, and let's take the liver, for example. It is possible to have a tumor the size of a football in the liver, easily resectable. Also possible to have a tumor the size of a peanut in the liver and be completely unresectable. So when it comes to many tumors, probably one of the most defining characteristics is location. It's all about location. And I tell, I use another example of road work or construction on the road. If a side street town requires repair, it's probably no big deal to shut that street off a little bit. But if you had to fix, Times Square, that's a big deal. You have a lot of traffic. It's a massive area where there's a lot of activity. So typically, it ends up being probably one of the most determinant features is tumor location. Next comes tumor number. Some patients have so much tumor spread that it's technically possible to remove all of it. those patients typically have features of many small tumors. It's just not possible to remove all those many small at times due to the complexity and extent of the surgery. I'd say so. I think to put it into the nutshell, number at times it's number, and when I mean number, I mean like thousands. I'm not talking about 10 or 20. If you had 1,000 small tumor nodules, it's not feasible to close, and then also ends up being location. Really is all about location at times.
Excellent. How likely is it that an offspring of a NET patient will also have NETs in their future? And a second part of that question is, if a child is showing symptoms, where would you take them?
That's a great question. So clearly we do know that patients who have pancreatic neuroendocrine tumors do have some chance of having a genetic or hereditary component to their NET tumors. Small bowel neuroendocrine tumors, less understood. And so obviously I think I would seek out a NET specialist, and then I would seek out genetic counseling. And then I think for no response or no adequate answers are obtained, then the NIH also has a genetic neuroendocrine interest as well. Seek them out also. But first, I would start with a NET specialist because they can help guide you to the right people. For pancreatic neuroendocrine tumors, the hereditary syndromes are pretty well characterized. Know a lot about them, so we can do the testing panel. Small bowel neuroendocrines, not so much. And as far as I know, although not my area of expertise, I will preface. I'm unaware of anything for lung carcinoids.
Excellent. Let's see. We have two questions here. I'll give you one, and then we'll follow it up with the next one. But for patients with short gut syndrome and diarrhea issues, do you suggest N-Trade?
Yeah, so obviously, I think that for patients who have metastatic small bowel tumors who may have functional component to their hormonal symptoms, and have short gut, it could be very difficult to parse out what is contributing. And to be honest, we may never know. We may never be able to identify. It's probably both factors contributing. So I do think there's diet entry, but some therapy for the short bowel syndrome to be entertained, whether that's small bowel lengthening or possibly transplant if the patient is a candidate for that, if their tumor burden is low or non-existent. I would seek out if you have significant small bowel resection, and you're not relief with your current NET provider, you probably should seek out a center that specializes in small bowel transplants, because they typically their patient is geared toward patients who have short gut syndrome. So I think it could be very, very, very challenging if you have both short gut syndrome, you have functional metastatic small bowel neuroendocrine tumor. And so I think and getting back to a previous common question, and patients have functional small bowel neuroendocrine tumors, you have to take out small bowel length. It's critically important that you be aware of what you're doing, because sometimes we do have to. One of my philosophies is to make sure that the cure is not worse than the disease.
Right. Absolutely.
And the sequelae of short bowel can be severe and debilitating. Oh, and at times very difficult to be reversed. Whereas now, we've made great progress with management of the symptomatology of diarrhea from excess hormone production from small bowel neuroendocrine tumors.
Great. For patients with carcinoid heart disease, do you prescribe Zermello to reduce the amount of circulating serotonin?
Yes, I do. Luckily, I don't see that too often, and I do then tend to also recommend a carcinoid cardiologist or carcinoid heart specialist as well, work in conjunction. I think it's important for patients to realize that most, if not all, particularly all the NET specialists, none of them work in a vacuum.
Right.
And so when patients come to see me per se, they're seeing not just me, but they're seeing all of the NET specialists at my institution. Now they may not physically see them all, but they're being discussed. So their ears may be ringing at times because they're being at a conference. And so I think that if any of us really operate without that support of other practitioners. And so, these decisions are often made in conjunction with a fair number of specialists. But if you have carcinoid heart disease, you do need to see a cardiologist with expertise in it as well, because we can control the serotonin levels so there's no progression, but the damage to the valve could be enough to warrant an intervention. And oftentimes we have to repair valve before we can do any other surgery, particularly liver surgery. If you have carcinoid heart disease, liver surgery is typically deferred until after the heart is fixed.
Great. Perfect. Can net grade change?
Yes. So that is a great question, an area of interest of mine, where, we like to think of tumors as being homogeneous and all the same, but it's the case. And so it would not be, we would often see frequently to have a low grade or a grade of 1 neuroendocrine tumor, but there are some areas in the liver that are growing faster than others. So it is very common for us to recommend repeat biopsies in these areas to determine if the grade has changed, because that does influence our treatment decisions for some of those patients when your grade does change. Although going from grade 1 or having, so I guess if you have multiple tumors, you should think that it's possible to have some heterogeneity in the grading in those. Now, however, I guess the important thing, it is very unlikely for a well-differentiated grade 1 or grade 2 to then really become a poorly differentiated, because that really is almost a different kind of cancer. So, but the grading of the well-differentiated tumors can not necessarily, you can have multiple different populations of each one in the same patient, but going to a high grade typically happens infrequently, if ever at all, because it's almost a different kind of cancer. I hope I explained that. It does get confusing, and patients often say, "Why are we doing another biopsy? We just did one, 2 years ago." Because we do worry about the aggressiveness of some tumors that may be different from other sites that we biopsy. So we do have to at times do multiple biopsies to delineate the grade.
Can
Absolutely.
I pop in
Great.
here, Mikey, with a
Go right
follow-up
ahead.
to that? Okay. What is the importance of a biopsy? If the results come back inconclusive or needing further assessment, should we be pushing for another biopsy?
Yeah, I think if a biopsy is inconclusive, then yes, another biopsy is typically warranted. I think a lot depends upon why was that biopsy inconclusive. If you're a fine needle aspiration with a little needle, yes, you probably the risk of getting inconclusive biopsies, and so you need to have a true cut or a needle biopsy or biopsy, which takes a bit more tissue to be analyzed. And sometimes it's sampling error, not so much not so much as a result of a person doing the biopsy, because many of us get sampling problems. We think of and we see on a CAT scan as being all tumor, but it could be half dead, or there could be inflammation along with it as well, and you tell the difference sometimes on the scan, where there's the dead tumor or the inflammation. So they're just doing biopsies randomly, and so you can get sampling error. I kind of equated my cookie analogy, where if I have a cookie chip, if I only put 2 or 3 chips, and then you were to take a biopsy of the cookie and not hit any chocolate chips, you would never know it was a chocolate chip cookie. But if I put in 20 chocolate chips, odds of the chocolate chip is pretty high. That's a good cookie. But so it really all depends on the makeup of the tumor, and so you can get sampling issues. But if information is needed from that biopsy and it comes inconclusive, then a repeat biopsy is done. And doesn't mean that the next one's going to be inconclusive. It just means it's a sampling. But yes, another biopsy if the information is critical for decision making. So that's another point. And please stop me if we need to move on. But I do think that we do a biopsy not just for the sake of knowing something. We do a biopsy for the sake of knowing something that's going to change what we want to do next. So if a patient is getting their therapy and they're doing well, we don't do a biopsy just because we want to check tumor per se for something. We're doing the biopsy if it's going to change our management for that patient, if we're going to do another therapy, or if we're going to institute something else. So it's important to know what the biopsy is for. Why are we doing a biopsy?
Thank you.
Awesome. Does having a bland embolization in the liver impact surgical removal of NETs in the future? Does it make surgery more challenging?
I guess that yes and no. Sometimes you can get some inflammation as a consequence of the bland embolization to the liver, but having a previous bland embolization would very rarely, if ever, exclude you from getting liver surgery. We've done it on multiple occasions doing surgery after bland embolization. But I know that we use surgery and bland embolizations different purposes, and I'm sure that will come up in a future question as well. So I'll wait for that.
Okay. What happens if liver tumors are too small to biopsy? Would it be possible to have treatment?
Yes, so that's very common. I have many patients now who have tumors in the liver that are too small to biopsy, but a dotatate scan confirms their activity. So I think if it's not biopsy, clearly, if we suspect metastases, a dotatate scan is a critical component of that workup. But if it's positive, then we will assume we will have great evidence that it's a that would corroborate that it is a neuroendocrine tumor. Could often treat just based on that alone if the dotatate scan was positive. However, if you had really small tumors, sometimes we even opt for observation and do nothing. And I have patients with small tumors who I've been watching for. I've got one I'm watching now for 4 years, and one I'm watching for 6, whose tumors are growing, like the Himalayas, of an inch a year maybe, and they're not doing anything. And so, observation of tumors is sometimes an option as well.
Great. What can be done if niacin is deficient? How do you check for this?
Oh, yeah. So that's a great question. And I think a lot of times these nutritional deficiencies that can occur for patients with neuroendocrine tumors get looked. And so, and sometimes it's through help of the doctors and the team, because sometimes we're focused on the patient and the tumors, and we almost lose sight of the significance of nutrition in these tumors. And so I think like us, like other places, we have active nutrition program as well for patients who have neuroendocrine tumors to try to help that. But there's a blood panel that we order for patients who we suspect nutritional deficiencies to correct, because yes, that is a common area of deficiency that does need to be addressed. To be honest, a lot of times a supplemental vitamin or a supplemental niacin is adequately aware of any deficiencies. Most patients, get enough in their diet. Supplementation with a multivitamin or niacin alone would be sufficient, more than enough to cover any deficiency. But it's a good question, because it does go back into that team approach of medications, and having a nutritionist who's aware of what can occur in neuroendocrine tumors, particularly the functional neuroendocrine tumors. Yes, because there's a lot of triggers, as as many of you in the audience know, for small bowel carcinoid tumors, lots of different triggers for carcinoid you have to be aware of.
Perfect. Will octreotide treatment help with the frequent face flushing?
Yes, it will. I think yeah, if you're it is, I guess, in sometimes the flushing and the tumors are true and unrelated. So I have patients who have neuroendocrine tumors and have flushing, but they're not related.
Correct.
And we know that from by measuring the whole hormonal tests, either urine or blood. If they're not elevated, if your serotonin and your 5-HIAA are not elevated, then flushing is not due to the neuroendocrine tumor. But if it is, then yes, octreotide can help significantly with the flushing. And I think almost about 2/3 reduction in flushing with octreotide.
Okay. What about Questran for diarrhea?
Yes, I think once again having a nutritionist on board helps us, because sometimes the diarrhea, octreotide, too much octreotide will give you diarrhea, and too much octreotide will shut down the function of the pancreas. The pancreas helps digest fat, and so the fat malabsorption, which leads to diarrhea. So it's strange, you're taking out to help with diarrhea from small bowel neuroendocrine tumors that are hormonally functional, and yet long-term use of it will cause diarrhea. And so then you have to supplement it with pancreatic enzymes. Well, knowing the difference between the component of diarrhea is critical, which can only be done at times with some testing and speaking to a nutritionist. So I think one size does not fit all, and require detective work and having a team help with deciphering which symptoms are attributable to.
Perfect.
It can be very challenging.
I have. I was just trying to frame this question properly, but somebody wants to know your opinion why a tumor in the mid pancreas was 2.5 centimeters, with later MRI at a size of 1.5 centimeters, and then later again show as 2.5 centimeters in the tail. They're likely the same tumor. Are they likely the same tumor reads from the scans? And how, as patients, do we align scans so we can understand what we are dealing with?
Okay, that is a great question. I think it's important to be aware that there can be differences in the appearance of tumors between MRIs and CAT scans. It could be challenging at times to compare sizes from MRIs to CAT scans. So if you have different tests and you had different measurements, doesn't mean that grew in between the scans. It just means that the detection ability or the imaging parameters of those scans are just a bit different when it comes to assessing the tumor. It really shouldn't change in location per se, unless you moved obliquely or you changed your positioning during the scan. So location would be odd, but we have seen some pancreatic neuroendocrine tumors get smaller, even spontaneously. It happens very often, but we do see it periodically. So that's why, and we try to get the same imaging test for our patients. And oftentimes we tend to use MRI more than CAT scans because many of our patients are getting scans, and I'd rather minimize the amount of CAT scans, which has some, although small, some radiation to it, whereas MRIs are units with no discernible long-term consequences. So it also allows us then to compare apples to apples and not apples to oranges when we get to different scans. I think without knowing more specifics, I think that would be the I have to leave it at that. Yeah. Different modalities and ultrasound, endoscopic ultrasound being another modality to look at pancreatic neuroendocrine tumors is also different. So patients will come to me and say, "Wow, my endoscopic ultrasound says that the tumor is even bigger than the MRI." Well, it's not bigger; it's just a different way of measuring it, a different modality, and we cannot compare the sizes between the three different scans. Nor can you use the dotatate scan as well, to compare size from a dotatate scan to an MRI to the ultrasound. They all look at the tumor differently.
Makes sense. Makes a lot of sense. We've got one here. Should someone without carcinoid syndrome change their eating habits once on lanreotide? Are there things that can increase symptoms?
Yeah, so if you're not hormonal, if you don't have hormonal overproduction of your tumor, but you're still being prescribed the lanreotide, obviously you're fortunate because you don't have any of the triggers that result in excess hormone function and the resulting carcinoid syndrome. But there are some dietary modifications for lanreotide, but something I would discuss with the nutritionist for further detail. I think that because in each patient it is, remember, the lanreotide does have some inhibition of pancreatic that can lead to other issues. So a nutritionist in this area would be a great resource, probably an underutilized resource. I think I'm always amazed to see patients come to see me who've gone to seek opinions elsewhere and spoken to a nutritionist.
Great.
Okay. What should you do if your oncologist and your surgeon disagree with what they see on a CT? Both are NET specialists.
Holy moly. That happens so often. And it happens very often. If I can permission to anecdote, because I do like telling anecdotes and stories, but I do think they convey points very well. About maybe 10, 12 years ago, I was speaking at a NET meeting, and there were a bunch of, and this was I think after the event was over, a bunch of us went out to dinner, all a group of NET specialists, surgeons, medical oncologists, a group of us. And one of the group, said, "Hey, I saw the most interesting patient with last week," and proceeded to describe the characteristics of the patient and their tumor and so forth, some interesting and unusual features. And several things became clear. One is that I think of the 12 doctors on the table, 8 of them saw the same patient at some point in the last year or two. So this one patient had seen 8 of the specialists at this table at 8 different institutions. From medical doctors to surgeons to radiation, the whole gamut. And then what also became clear is that each one prescribed a different therapy or recommended something different than the others. And they're all, we were all, experienced, knowledgeable net specialists. But each one recommended something a little different. And it became clear to me that there's not a right or wrong for patients, just a different approach or philosophy. And I live on the East Coast, and I have family in California and San Diego. To drive from New York to San Diego, I can take many different routes to get there. I can go northern, I can go southern, but I do have to cross Mississippi. I have to cross the Missouri River. I have to cross some mountains to get to San Diego. But how I get there is multiple choices. And so I think goes for neuroendocrine tumors. You do have to get a path from point A to point B, but how you get there or what treatment you can take sometimes is of the philosophy of the doctor per se than science. But none of these doctors prescribe something crazy or wrong, just different. And so it's important to realize for patients that not everyone share the same opinion, because they may have different philosophies of how they want to treat the tumors, even though they're net specialists on their own right. And so, yes, I've seen patients for third, fourth, fifth opinions, and they're like, "Wow, yours is different." I say, "Well, this is," and I explain why mine is different and what my philosophy is on treating patients. And if they like that philosophy, then they stay, and if they don't, then they seek other opinions. But they're going to get different. Doesn't mean that the other doctors are wrong. It's just different, still acceptable, but just different. I think that's challenging because unlike other doctors, if you had colon cancer or lung cancer, you're probably going to get the same opinions at different places. But that is not the case typically for tumors. Doesn't mean that they're wrong, just different philosophy.
Sure.
Thank you. If shrinkage of a tumor is needed prior to surgical removal, what is the best route to achieve that?
Yes, another great question. I'd say that many of the treatment modalities have now are designed to control the growth and prevent growth and growth size. And really only 2 treatment options that have the ability to shrink tumors, and that chemotherapy, so capecitabine and temozolom, and Lutathera. Both of those tumors those treatment options have been shown to decrease the size. Now, obviously, Lutathera would take a long time for that to happen. The Cap-Tem chemo option may occur sooner. So if we need patients to have tumor shrinkage, oftentimes we will do the chemotherapy option. Now, if the tumor shrinkage is required in the liver, sometimes even a radiation or Y90 to that liver spot as well can help get some tumor shrinkage as well. So once again, location of the tumor and what we're trying to have it shrink away from are 2 important characteristics that we required for planning. But that's a great question because it does it is important at times to pick the right therapy.
Thank you. Can you explain and also give us a little bit of insight into what it's like sitting on a tumor board? Like what happens when you take a case to the tumor board or
Yeah. Okay.
that.
Yeah. Okay, great. I guess yes. Patients typically may not be privy to that kind. It happens. To us in the field, it's a constant, weekly, if not twice a week phenomenon. So I guess for the mechanism, if I see a patient in clinic and I want input from the group, and for many tumors, we do want that to happen. You submit a name, so then prepare and get all the scans, get all the pathology. A radiologist will review all the radiology. A pathologist will review all the pathology. Then on the day of the tumor board, someone will give a synopsis of the case, a brief overview. This patient is 64, has this, was treated here, blah 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 blah. They'll show some pathology. They'll show the scans. They'll discuss the points of controversy or concern, and then there'll be a discussion and forth. Now, and then the results of that tumor board are sometimes written down, but most of the time are then conveyed to the patient. Sometimes there's unanimous agreement, which is great. Sometimes there isn't. Many neuroendocrine tumors, and so I'll tell my patients, okay, these were the two options that were decided, and 60% felt you should have option A, 40% option B. We all think that option A and option B are reasonable, but 60% favored the A versus the B, and so forth. And neither of them may be wrong, but this is what we thought, and we may then choose option B or choose option A going forward. So I think when patients hear that they're being discussed with tumor, asking your oncologist, okay, what was the discussion or the outcome, is reasonable and should be effective. We typically notify our patients afterwards what the decisions were. Discussion.
Great. I've got a few.
I'm sorry. I think that's all to add for patients then to say, was this unanimous? Was there agreement? You may want to hear what other opinions were.
Sure. I've got a couple of questions here. First off, somebody misunderstood your comment on tumor shrinkage. Could you elaborate just a little bit more on that from that last question?
Yes. So obviously, we all want tumor shrinkage. That's the goal when we do cancer treatment. But sometimes if it has let's say a pancreatic neuroendocrine tumor that's involving too much to be removed, oftentimes we may want that tumor to shrink so we can technically remove it without injury to the blood vessels critically attached to it, so we can remove it safely. So in that case, I recommend someone get the chemotherapy, which has been shown to result in the best or most durable option for shrinkage of a tumor to make the tumor then resectable. But if the goal is not for surgery per se, then tumor shrinkage is necessarily always the outcome we want. We also then want, tumor stability and prevention of tumor growth, if that makes sense. So I guess if you had 15 or 20 spots in your, and we're giving you bland embolizations, we're not expecting those tumor spots to go away per se, but we're expecting for those bland embolizations to then kill that tumor so that it doesn't get bigger or spread further. Whereas if we're talking about a tumor that's too big to be removed or involving a critical structure that we want shrinkage or surgery, then we employ something different. So I guess the objective of the therapy has to be, why are we giving the therapy we're giving? And I think that's a very reasonable thing for ask, say, okay, why are we choosing this therapy? What is the objective of this therapy going to do? You know, and I guess if you can't get a good answer, then maybe you do need somebody else.
We also have, is octreotide an old therapy? Is there a more updated treatment?
I'm old enough to know when we didn't have octreotide, so I think of octreotide being a new therapy. And another story, I recall a patient who had metastatic small bowel neuroendometrioma for about years, and we've been watching him for 4 years, and he's had no tumor growth at all over those 4 years. It was pre the data for octreotide. Then big in the journal, octreotide helps with neuroendocrine. He comes to me and says, should I on this drug now? You know, should I get this drug so it can slow my tumors down? And I said, John, I said, you know, your tumors haven't grown in 4 years. It's harder to make it grow any slower. You know, how can I make that grow slower? And he's like, yeah, you're right. We saved octreotide for when there was tumor growth, which didn't occur 3 years later. And then we put him on octreotide. So I don't think of octreotide being a old an old treatment option. I think that hopefully maybe we will at some point advance and have more types of octreotide to be more sensitive or more responsive to the tumor per se, but I don't necessarily think of it as an old treatment because it definitely wasn't approved when I started therapy. So I think it was something new. So, but I do realize, like, from a patient's perspective, it's been around for a long time. But I still think of it as something new. I don't think of it as it's an important component of the armamentarium for treating this tumor.
Great. What happens to tumors in the liver when they've been treated with Y90 or embolization? Do they create fibrosis or cirrhosis?
Yes, a great question. So we really want to avoid cirrhosis at all costs. So cirrhosis is when there's evidence that the entire liver has been damaged and the liver becomes, as opposed to being spongy, it's more like concrete or hard as a rock. We don't really want that. Now the way we avoid that problem with the embolizations and the Y90 is when they're doing these procedures, they are hopefully, and almost all the doctors I know are treating the blood vessel directly to the tumor to avoid collateral damage to normal liver. And many times patients will say, wow, you know, we can do the bland embolization, you can still see the spots on the scan, on an MRI or CAT scan. And what we were hoping for is for that entire tumor now to be dead or scarred. So we do want, you know, that would be a desired goal to have that. And if they were to get a dotatate scan, there would be no activity or markedly decreased activity in that. That would be a goal. Now, bland embolization should never lead to cirrhosis. Y90 also typically will not lead to cirrhosis, but Y90 does with the radiation, can have some more collateral damage to the liver, which we do try to minimize as well. And that is an important consideration for me when I recommend, you know, Y90. I've had patients with metastatic neuroendocrine tumors who have lived, 20 years. If I gave them Y90, I could really be suffering the consequences of that, some of that radiation effect to the liver, 20, 30 years down the road, which I don't want. So that is a consideration at times when utilizing Y90. It is for me. And I do like bland embolization for the fact that it has very little downward effects on the liver afterwards.
Great. All right, we've got two last questions here, and then we're going to start wrapping up. What is your opinion on Afinitor, and what does it do?
Yes, great question. So, a Afinitor. So, I view a lot of these as options in the management of neuroendocrine tumors. And there was a time when all we really had was, or at least Afinitor was one of the few good options. I do see that we tend to use it less in my patient population. I see the medical oncologists prescribing less, but I think it's an option to be discussed in patient. And my philosophy is I probably would use Afinitor maybe before I would go to chemotherapy option due to the toxicity or the side effects of the chemotherapy as opposed to Afinitor. But a lot also depends upon the tumor growth, the tumor location, things of that nature, some of the intangibles, which is why when we discuss some patients who may have metastatic, let's say pancreatic neuroendocrine tumor, and we discuss them in our tumor board, we give them 4 or 5 different we may recommend those 5 different patients, and because a lot has to do with the tumor location, the tumor growth rate, patient tolerability. So I think I do think Afinitor is a drug in our tool belt in treating this cancer.
All right. And our very last question here, I want to bring it back to the tumor board thing. Are tumor boards local to net specialists or to the local net specialists, or do you confer with other specialists either around the country, around the globe, et cetera?
So typically for most patient timely treatment decisions, it's local. Partly because there's, not to my knowledge, a national or international tumor for discussion that would occur on a timely basis. Having a symposium 2 or 3 times a year may not do a patient a favor if they have to wait 2 or 3, 4 months for them to be discussed at a conference, whereas these tumor boards are occurring weekly in the hospital area. That's not to say that I'm call or I get phone calls from my other colleagues saying, "Hey, I have a patient like this. Any thoughts? Would you recommend this or that?" That happens, but not in a formalized mechanism like a board per se. So I think that's why I would imagine many patients may seek opinions at multiple places for that reason per se, so they can get another opinion. But I think it's important to note that if when another doctor or another specialist and that opinion does not match, that doesn't mean that the other net specialist is doing something wrong. It just means that their philosophy in treating the tumor is a little different than the other one. And like I said, when we had that group of 12 doctors and 8 of them, the same patient and all recommended something different, it was very clear to me that they were all bright, they're all smart, and I could see the rationale for why they did what they did. But philosophically, each doctor has their of treating it. And for the same patient who commented earlier about how well, especially they have 2 net specialists in their own hospital, and they recommended something different, or they used some. That's the art of the medicine as opposed to the science of the medicine. Doesn't mean it's wrong. It's just art.
Great. Everybody, thank you so much for joining us today. Unfortunately, next month we will not be doing another Q&A live stream. We're going to try and stream some stuff from our conference out in Silver Spring, Maryland on March 11th. So stay tuned for that. We'll try and send out another registration and try and get a thing on the schedule to do it. Our next one will be in April with Dr. Jason Starr. Again, it will be in April, second Saturday in April. It'll start at 12 p.m. Eastern. Trish, thanks for stepping in for mom and dad.
No
Mom or
problem.
dad. I know you don't love being on camera, but you did a great job.
Oh, thank you.
Yeah.
Thank you. And
And-
thank you, Dr. Sasson. It was great
Yes,
speaking with
thank
you.
you, Dr. Sasson. Thank you for joining us. And everybody, for more information on anything we have going on with NCAN, go to netcancerawareness.org. You'll find out more stuff, and we'll have another Q&A here next time. So thank you, everybody, for joining us. We'll see you next time.
Thank you, everybody. Thank you, Mike and Tricia, for having me.